Hi there. I'm Dr. Aaron Weiner. I'm a licensed clinical psychologist and addiction specialist, and we're here today to talk about understanding, detecting, and addressing youth substance use and how you can understand why kids are using and then how you can respond within the context of family medicine. Before we get rolling, just a couple quick items for housekeeping. The first is that today's webinar is brought to you in partnership with the University of Arkansas Little Rock Mid-South Division and the University of Arkansas for Medical Sciences, Community Health, and Education Division. Additionally, if you have any questions about today's training, please feel free to reach out to me. My email is here on the first slide. It'll also be on the last one, but I'm happy to answer questions, provide primary resources, whatever would be useful or, to help better understand this really important and critical topic. So with that, let's dive in. Lots to talk about, only 30 minutes to do it in. And what I'd like to start with is an idea that whenever we're thinking about behavior, and this goes not just for kids, but for adults as well, is a good truism to live by, which is that behavior is always purpose-driven, even if it doesn't seem to make sense. And what I mean by that is that we can look at someone's behavior and say, well, I don't get why this is happening. Like, it seems like they're doing something that's counterproductive to their goals. And maybe to some of their goals, that is absolutely true. However, if someone is doing something that seems like it's against their interest because, say, it's causing problems at school or with parents, etc., but they do it anyway, that means that whatever they're getting from doing it is more powerful for them. It means more to them than whatever the consequence is. And so we need to understand the why. Why is a young person doing something like, say, using substances, in order to then help leverage that understanding towards change. And so what I'd like to start with is to reframe bad behavior, or again, these aberrant behaviors that are unhealthy, seem atypical, as instead of just being bad behavior, that they are communication, or rather that they are the tip of an iceberg. And I'm drawing here from Stuart Shanker's self-reg model. But what he proposes is that unexpected behavior, what we can see, is just the tip of the iceberg, and what actually is beneath it and what's holding that up is a complicated, potentially, sometimes simple, but a web of potential influences, like biological influences, emotional, cognitive, social, and then prosocial, which is like what a society expects of you. And that oftentimes when someone's behaving in a way that feels off, what's actually happening is one of those 5 areas isn't being addressed properly. They have a need that isn't being met. And so the behavior is actually just trying to compensate for a lack in one of those areas. And that if perhaps we help the child meet that need in a healthier way, we might see the drive towards that negative behavior to come down, right? We wouldn't see that same push towards it because they don't need it in the same way. And so the lens shift here is that the acting out is actually just a child trying to complete their stress cycle and to regulate themselves. They're meeting a need. And so again, to underscore, we want to focus on the why, not just the what. The what matters, but the why also matters. Put another way, unhealthy coping comes from discomfort. When you feel really uncomfortable, like if you think about emotions on a continuum, and that on one far side is where you have the very extremes of that, like you're very angry, depressed, anxious, etc. When we start getting down to this end is when we react by doing something that seems, at least in the moment, to help, like addictive behaviors, eating disorders, hoarding, cutting behavior, all those types of symptoms. It's all because there's an emotional need that feels like it's being met. And so why this is so alluring, why this is so difficult for kids in particular to resist, is because of how the brain works. And I like to think about the brain as having 2 competing processes when it comes to stress and when it comes to coping with strong emotions. A really advanced thinking side, which is our prefrontal cortex, and a more primal feeling and urge side, which is our limbic system. And so I like to imagine this as if in our brain, we've got a really advanced car like a Tesla, but it's being driven by a dog. And particularly when we get stressed out, that dog grabs the wheel. The limbic system grabs the wheel from the prefrontal cortex and says, hey, you know what we need to do right now? We need to not be in pain. We need to not be uncomfortable, because that is the number one thing that our limbic system wants, is to not feel discomfort. The second thing that it wants is to feel pleasure. And so substances feel like they check both boxes, because they can both numb out pain and create this euphoric state that feels good. And so that part of our brain, the dog, what I like to call the dog driving our car, loves this. It says, wow, I was feeling stressed out about the test that was coming, or I was feeling socially anxious, but now that I'm drinking, I don't feel that way anymore. It's gone. And not only that, but I'm feeling pleasure and my peers are accepting me. This feels like a solution. And the problem is that it's not, ultimately, right? It can be damaging their health in the short term, their prospects in the long term for any number of different ways. But they're not thinking about that. And actually, their brains aren't even wired to think that way yet. Our brain isn't done developing until we're about 25. And the last part of the brain to develop is the prefrontal cortex, the car in this metaphor. And so even if we were to say, all right, so maybe the child has a better idea of the big picture and wants to work with, better within that urge, they don't have as much to control that urge with, because their prefrontal cortex isn't as developed as an adult's would be. And so it's very challenging oftentimes when kids are experiencing discomfort to control their behavior and act in healthier pro-social ways. And the problem is that right now, kids are feeling a lot of emotional pressure and tension and negativity. We could dissect a lot of studies about this if we want to. But the one I'll show you today is this one, which was the National Youth Risk Behavior Survey. This came out, this is the most recent data we have at the time of recording here in June 2024. And what they found in the survey that went out to high school students in 21 was that about 4 in 10 said that they experienced one of the core symptoms of clinical depression. 1 in 5 kids seriously considered attempting suicide or made a plan, and 1 in 10 kids attempted it, although only a third of them made it to a doctor or a nurse. But if we just step back for a second and think about the fact that 1 in 5 kids right now says that they have seriously considered attempting suicide or made a plan, and that 1 in 10 have given it a try within a year's span, that to me is a huge warning shot. Like we need to pay attention to this. We need to respond to this, because kids right now are struggling. And again, substances feel like a solution to those struggles. If they are feeling anxious, if they are feeling stressed, they're feeling down, whatever is going on, it can feel like a solution. Now, the other element of this that I alluded to that is very strong for young people in particular is the social side of this. And if any of you took Psych 101 in college, you might remember back to Erickson's psychosocial developmental stages. Our goal, like what we're shooting for in our development in high school, is to figure out who we are, who we're not, who we fit with, who we want to be. And so socially, if there's a group of people who you'd really like to be a part of, and they all drink, it's really hard for you not to do that and still be part of that group. Or if your friend group, when you were younger, started drifting towards vaping, it's really hard for you to be like, yeah, you guys go ahead, I'm not going to do that. Or just to hang around with them and they're offering it to you and you're saying no. There's a lot of sometimes explicit peer pressure, but sometimes just implicit peer pressure where you don't want to be on the outside looking in. And particularly, again, for young people, this can be very... this can really push them towards doing a behavior that they otherwise might not do. And all of this feeds into the fact that by their senior year, about 70% of kids have tried alcohol, 50% have used some illicit substance. We are including THC in here, despite its semi-legal status, at least 21 and up in some states. 40% will have vaped or smoked a cigarette. 20% will have misused some sort of prescription. And this is all feeding into the fact that 16.5% of the general population has a diagnosable substance use disorder. About 12% of that is alcohol. Now, that being said, if someone's going to have an addiction at any point in their life, 90% of them have their first one when they are teenagers. And that's part of why, when we think about prevention of substance use and why it's important to catch it early, why we care so much about this. because if we catch it early and we stop a young person from going down that path, or rather, perhaps I should say they stop themselves when they understand more of the paradigm, then if they stop before they hit that first addiction, they're much less likely to have one across their life course. Now, pushing back against that are the social pressures that we talked about just a second ago, but also one of the aspects that makes substance use, and addiction so unique is there are literally industries out there that are trying to sell you this problem because they make money off of you, and they make more money off of you the worse you have this problem. And this makes it very different from anxiety, very different from depression, because no one is out there selling those things to you. No one is making money the more anxious you are, at least not directly per se. But literally, that's what addiction for profit companies do. And in particular, because 90% of people who have addictions start when they're teens, and teens don't have that fully developed prefrontal cortex, what we find is a lot of ads, and this is the Juul launch campaign. It has to date cost them about $3 billion in settlements and has turned them into a shell of the company they once were. Is that when you look at this campaign and you look at the models that they're using, they don't look like 55-year-old chain smokers. And there is a reason for that, right? Who are they speaking to with these ads? The other thing that they did in particular, and this is part of why vaping has caught on, is that they delivered a stronger nicotine hit to the brain than even regular cigarettes, and a lot stronger than earlier e-cigarettes. Juul created what now is, I'd call, industry standard of nicotine salts, which hits the brain with nicotine even harder, which could theoretically in some cases be abrasive. But the other thing that vapes have layered in are flavors. And this is a tactic that we've seen used in the nicotine industry for years. It's why we banned flavored cigarettes in 2009. And that's because flavors disproportionately appeal to young people. And when you ask teens, why do you vape? 90% of them say, like, one of the main reasons is for the flavors. At least that's what got them into it. And this is again, nothing new. If you look at the master settlement agreement, there were just document after document after document that showed behind the curtain of what Big Tobacco was trying to do. And they were very clear about it, right? We know that 14 to 18-year-olds are an increasing segment of the population. We've got to make a new brand that works there. Joe Camel exists because that is what cool looked like to teenagers, right? That's what they were trying to emulate. And that's what they were saying in their internal documents. There's this perception that Camel smokers are nonconformist, self-confident, project a cool attitude. We know that this influences younger adult, it says here younger adult smokers, but let's be honest, right? Who else is rebelling? And this is something also that bridges over into THC. And then those are the top three chemicals right now that we're seeing young people using. It's THC, marijuana, it's alcohol, and it's nicotine. But there have been articles, and this is just one, that show what are the tactics that these companies are using to, if not directly, obliquely appeal to young people. Just a couple examples from where I live, around in the Chicago area. This was a dispensary that was handing out their swag to kids at a summer fair. When given an opportunity to apologize, they didn't. Here's another example of them using a raccoon as a mascot, which actually was illegal and still is to do at the time. And eventually they had to take it down. But what made this even more egregious was it was actually down the street from an elementary school that has a raccoon as its mascot. And if we pivot over to alcohol, we see companies like Mountain Dew leveraging their brands, which we know are primarily consumed by young people, high school students and college students, leveraging their brand to create hard alcoholic beverages. And so this is the crucible that kids are in. They are stressed out. They are struggling. They have gone through just a period of immense upheaval during the COVID years, and they're trying to find coping solutions. And if they don't find them, either for their emotions or for the social pressures they're feeling, substances can feel like a shortcut for all of these things. They feel like they work, but when you use them every day, or when it's part of how you define, like, how do I hang out? How do I socialize with my friends? You start getting yourself into a pattern that can turn into a very problematic habit. And so what we can do then, what can we do is the big question here from a family medicine perspective. And what I'd like to do is use the acronym that the American Academy of Pediatrics is suggesting around detecting and responding to substance use in adolescents, which is ACT. Ask, counsel, and treat. And this is a bit of an offshoot from SBIRT, which is screening, brief intervention, and referral to treatment, which if you've watched any of the other trainings or you plan to, is something we'll talk a little bit about there. But this is what ACT looks like. And again, similar in a lot of ways, but a little bit different in others. And what you're looking at here, and we'll come back to this model throughout this section of the training, but you start by screening, right? In the past year, how many times have you used tobacco, alcohol, marijuana, etc.? And then depending on whether or not there's no use, once or twice in the past year, monthly use or weekly use, you then adapt your approach to fit. And so we're going to talk a little bit first about contextual factors around this, and then go through each of those trees briefly so that you can understand how to go through this in a way that is in accordance with what the AAP is suggesting. So let's first start with these contextual factors. So the most important thing is to start this conversation early, and that's because you don't want to have to push back against existing inaccurate narratives. If you're trying to work with an adolescent who already has been reading all about these chemicals, so social media like Snapchat and Instagram, and if they're on Reddit, and if their friends say this, and now all of a sudden you're trying to talk to them about maybe some of the actual science behind THC or vaping or alcohol, it is a lot harder than if you talk to them before they encounter it out in the wild. So ideally 11 or 12 years old is the best time to be talking about this, to preempt, maybe even a little bit earlier, 10 if you want to. But you want to normalize the conversation, kind of like you would with sexual activity, where it's something where this is just part of your checkup. This is something we talk about as part of behavioral health, as part of treating the whole person. And so it's not like we have to be uncomfortable to talk about substances. This is just all part of the check-in, all part of the checkup. Now, this also is going to require some degree of confidentiality. And so it's important to talk to the parents about that so that they know what those limits are before then asking them to leave. Because there might be some topics that the child is open to sharing with you that they feel uncomfortable sharing with their parents. And that can be okay. And we'll talk more about confidentiality in a minute. That said, you've got to build trust over a period of time. And so this is something where people don't just trust you from jump. We'll talk about a way to get there in a second, more specifically. But rapport takes time and consistency. If you think about emotions, like trust is, if you trust someone, that's an emotion. It's not so much a thought, like I can trust you. It's feeling like I can trust you. And feelings don't come from arguments or saying like, I'm your doctor, you can trust me. That's not going to inspire trust. What's going to inspire trust is being trustworthy, being there, being consistent, being helpful, right? Proving it over time that you are on their side. Another thing that will very much help with rapport is emphasizing autonomy, because kids don't have a lot of this. A lot of kids' lives are very scripted. They have to do specific things. And that's part of where that pushback comes from, right? They feel pushed into a path, so then they push back to try to feel autonomous. One really easy way to emphasize a child's autonomy is to acknowledge them first when you enter the exam room. You might already be doing this, but if not, consider giving it a try. Say hello to the child first, before the adult, before the parent, because that lets them know this is your appointment. Even if they are not fully in charge of the situation. Last thought about this, for kids who are hesitant to disclose, quietness does not mean that everything is fine. If they don't tell you just straight up, or they're not eagerly volunteering information, that doesn't mean that everything's fine. It might mean that they're just very nervous about it, or it's hard for them to share. And so it's that doesn't mean that we need to pry it out of them, but at the same time, this is part of why it's so important to ask. So some other contextual factors to consider, confidentiality, a little bit more to say about this. It is essential for honest reporting, and so limits around confidentiality with adolescent patients, of course, are suicide, self-harm, intent to hurt others, an imminent or serious health impact. But where you draw the line on, say, for example, imminent or serious health impact, that is up to you. But at the same time, if that is the case, you do have to disclose that. But you can also reinforce that to the child once the parents leave. Basic substance use, say of like alcohol, of THC, I would say the majority of providers would say that does not qualify as imminent or serious health impact unless it's a very an intense use pattern, one where you actually do feel like there's an imminent or serious health impact. But letting the child know that they can talk with you, and it's not just like you're going to turn right around and tell their parents, means a lot. The way you speak with them also matters. You want to have a non-judgmental tone, non-threatening, diffuse emotional charge if it's there. And one way to broach the subject that feels less threatening than just asking, like, are you vaping, are you drinking, is to ask them about their peers. So you can say something like, I know some kids your age use alcohol or smoke or use other drugs. Are any of your friends into this? Right? That's a very easy way for them to talk about the subject without making it necessarily about them. And then you can continue to ask them about what they think about it. So like, how do you feel about that? And that can be, again, very easy entry point. At a certain point, if you haven't already asked it in a screening document, or if you have and you just want to follow up, that's when you can ask, so is this something that you're doing as well, or are you just noticing it, for example? Now, in terms, though, of how do we conduct this ask, counsel, treat dialogue in the most effective way possible, the term and the skill we want to lean into is motivational interviewing, or MI for short. And this is where we do that brief intervention, or counsel in this case. It's a research-backed approach to catalyzing behavioral change. And it's something that, again, if you're trying to get someone to follow through and they're not right in front of you, taking this approach where you're collaborating with them to fan the flames of their own motivation, rather than you saying, here's what you need to do and why. But you are meeting them where they're at and having a dialogue, which can be very short, but you're having a dialogue to help them figure out, well, what do I really want for myself? Where do I go from here? A way to think about this is you're finding positive goals inside of ambivalence, and you're enhancing the motivation for change. And so remember, if someone's ambivalent, like if they're thinking like, oh man, like I know like a lot of my friends are vaping, I don't know if I want to do it. That's ambivalence, but there's also clearly in ambivalence questioning, right? They don't know what they want, but that means that part of them is interested in that healthier choice. And so what you're trying to do is join with them in the ambivalent place and help structure a conversation where we enhance the amount of change talk, is what it's called in the theory, but where they talk about why they want to go in that healthy direction. And we're developing this discrepancy between the current state and their goals. So if you have a child, say for example, who cares about their future, about their health, about being the best version of themselves, and having a healthy body and mind, but at the same time they're drinking, it's possible to actually create a place of cognitive dissonance around that. Cognitive dissonance is when you have one set of beliefs, but then your behaviors, your actions don't back up those beliefs. They go in a different direction. And that feels really uncomfortable. And we're driven to resolve that tension. And so what you want to try to do is just create the juxtaposition. Like, hey, like I hear you that you care about your health and your wellness and your friends, and at the same time you're doing this behavior that is actively causing you harm. Let's look for a solution in there, right? Is there something that feels like a change that could make you feel a little bit better about all of this? This type of dialogue, though, and this book, by the way, that I have here on the right, super accessible, really easy to read, highly recommended if you'd like to learn more about this, but it should feel like dancing, not like wrestling. So it shouldn't feel like you're trying to convince the child to do what you want them to do, like you shouldn't be smoking. Here's why you shouldn't smoke. Here are all the things you're doing. You're not going to do it anymore, right? You're going to drop it. You know, that's wrestling, right? I'm going to just make you see the right way to do this. What this is advocating for is more of a back and forth, where you're asking like, hey, how do you feel about this? Do you have any doubts? Is it having any negative impact on your life? How confident, how important do you feel like it might be to change? We'll talk about specific interventions in just a minute. It should feel more like dancing, less like wrestling. So to have this dialogue effectively, we have to communicate in a way where young people are receptive. And there's a great acronym for this that was coined by the Center for Motivation and Change called Communicate with Love, which stands for listening, offering, validating, and empathizing. And if you communicate with a young person in this way, it's going to enhance the chances, one, that they trust you and that you develop that strong rapport, but two, that they'll actually listen to you. And they'll take actions based on what you've been speaking about. This builds emotional safety, where they feel like they will disclose to you and that they can really pick up what you're putting down. So let's go through these quickly. The L of love stands for listening, or active listening, which means you can't just assume that your patient knows that you're listening to them because even you're just looking at them. Nonverbals help, right? Like if we look at this picture, we can see that he's, making eye contact and, very interested, but what you say also really matters. And there's two ways in particular I'd like to highlight that you can demonstrate to someone that you are listening. Reflections and open-ended questions. I'm going to start with reflections, even though they're in the different order on the slide. Reflections means you're taking in information someone's giving you and you're returning it to them, but in different words, or you're giving voice to an emotion that they might have been emoting at you, but not saying specifically. So if you've got a young person there who's talking about how they have been vaping, but they look really uncomfortable when they're saying it and they're looking down, or they look frustrated, or whatever it may be, if you respond to that by saying, it sounds like, or it looks like you're not entirely comfortable with this. Is that right? And that would be a reflection. You're reflecting back the feeling. Or if you're reflecting more content back, just simply repeating something like, if a young person says, it's really tough because all my friends are drinking and I go to a party and I don't want to, but I feel like I have to. Even just putting it back at them and saying, so even though no one's saying, like, actively peer pressuring you, you feel a lot of pressure to drink. That's different words, but you're showing them you get the meaning. And that feels really good. People love to feel heard. It's almost like I'd say like a central emotional need, is to be seen by another person or by other people and understood. It feels fantastic when it happens. So it's very easy to show someone you're listening, but you do have to do it intentionally. Reflections are a great way to do that. An open-ended question also shows that you care, because these are questions that you can't answer quickly. There's not a quick yes or no. So an open-ended question would be a question that starts with like, tell me more about fill in the blank, or why do you feel a certain way, or how does this work for you? They're not like, are you vaping? Yes, right? It would be more like, could you tell me a little bit about your feelings around vaping? That's open-ended, right? And so it's saying you care about the details. And then if you follow that up with more active listening, where you reflect it back, that shows someone that you care. So that's listening. O stands for offering. More specifically, how do you offer information in a way that makes it most likely to be received and acted on? And the way that I'd recommend doing it is something called a feedback sandwich, where you sandwich your guidance between two slices of autonomy. So the first slice is asking permission to give the advice. So this is something where, instead of just saying, here's what you need to know about marijuana, or here's what you need to know about vaping, and here's why you should do something different, you're saying something like, hey, like, I know some information about vaping that I think would be useful to you. Do you mind if I share it? And that might honestly take some patients aback, because they're not used to be asked permission to be given information or advice, particularly, say, by their medical provider. But if you do that, what that means is that they have asked you for your opinion. It is the opposite of you pushing. They have consented to hearing it. And they're actually taking some ownership. There's some part of them that is taking ownership over that answer, because they've asked you for it. So once they say yes, and if they say no, we do have to respect it, of course. But if they say yes, then you give the feedback, you give the guidance, ideally more than one option if you can, and so that they could choose what they like. But then afterwards, you ask them for their reaction. How do you feel about this? Do you like it? Does it seem like a good idea to you? And what that means is that if they agree, they will have asked for the advice, they will have heard it, and then they will have decided for themselves, and out of their own mouth, if they like it, they'll say, yeah, like, it does seem like, this solution is about, whatever it is that you're offering. They'll say, yeah, I think it's useful. And that maps much more closely to actual change in action than you just saying, here's something that you can do, without being asked and without asking for their opinion about it. So that's offering. The V stands for validating, where you can validate somebody's feelings, like that emotional underpinning behind behavior, without endorsing the behavior itself. So if, say, for example, a patient is drinking, and although, of course, as their healthcare provider, you're not going to say, like, yeah, there's no health risks associated with this as a teenager. What you can do is you can ask into the emotional side behind it, and you can let them know that you see them, that you understand that they are okay. Those feelings and emotions are okay, even if you have to recommend potentially a different behavior, because the behavior, how they're meeting those needs, isn't ideal for their health. The E stands for empathizing, and empathizing, where I think we're all fairly familiar with this term, but to borrow a phrase from Brene Brown, you want to get in a hole with somebody. Like if someone's in a dark hole, you want to get in there with them, get next to them, and show them that you understand. Not just say, I know how to save you. I know how to carry you out of this hole and away to somewhere. That, although you might have the right answer, actually comes across as very disempowering. It's not as welcomed as first seeing someone, listening, validating, and then potentially offering that feedback sandwich, right? Saying like, hey, I think I know something that can help after you join with them in there, and then moving them along. So that's what communicate with love means. Listen, offer, validate, and empathize. And if you give that a shot, you might find you get very different reactions from patients than if you aren't doing those things right now. And the last thought on this before we move on, remember, this is a long game. Like this is something where ideally we're starting when they're 10, 11, 12. We're talking with them over time. And even if you're catching a young person after they've started, it's okay to go slow. Schedule a follow-up if they're not already hooked into other care that's more like a specialist or behavioral health. It's okay to schedule a follow-up. You don't need to get them to change their behavior right now. Right? This can be something that you can do slowly over time. So let's get back to our model. We've talked about these. How do you, generally speaking, have the conversation? Let's drill in now to, for each of these categories, what we can do. So if there's no use, what we're going for there is positive reinforcement. And this is really important because physician reinforcement has been shown to have a positive impact on delayed onset of use. So if you say, hey, great job for not using substances, that was a healthy choice on your part, they're more likely to stay that way because behavior we reinforce is more likely to be repeated. Think about how people get on substances in the first place. They use them, they get reinforced, right? Their peers are, maybe appreciate it, they feel less stressed, whatever it is, but that reinforcement is what brings them back to doing it again. And so you can leverage that same principle by reinforcing it and saying, hey, that was a healthy choice. I can appreciate that. And because it's tough to do that in today's world because substances are around. You can frame this as a conscious choice. And what you can also do is provide a normative correction. And this is actually really critical. Most kids don't realize past year use of even alcohol, less than 50% of high school seniors say that they've used alcohol in the past year. That's where we are right now in our country. And actually it's even less than that for THC, marijuana, and other substances. Under half. If you ask kids about this, they will not, that is not what they think. They think a lot of their peers are doing it, even though they're not. And so this is a chance to give what's called a normative correction. Like, I'm glad to hear that you, like a lot of other kids your age, have never tried this, or have not done it, or have chosen to go in this direction. It's not easy, but you can make the right choice, or the healthy choice, if you will. You can do that if you'd like to, because again, this is true. This is what the data is showing us. It's not most kids who are using, it's most kids who actually aren't. But reinforcing that is important. When we reinforce a behavior, we're more likely to repeat it. So let's say though we're in the once or twice. If you ask this question or use a screener and they are using substances, if it's just occasionally, this is where you can give this brief advice. And now ideally, this is where, again, you ask permission, feedback sandwich, but what you want to do is give clear advice to stop using it because of the negative health effects. We've seen from research that this decreases or eliminates use for adolescents who are using it very infrequently. If they trust you, if they care about their health, that infrequent use means they're just kind of experimenting and they're not sure what they want to do yet. So if you, as a trusted adult, come and say, hey, I can understand the appeal, and this is actually really harmful for your health for this, that, and the other, and the healthiest thing for you is not to do this. They're going to listen to that, and they will care about that, at least, again, from a population level. That's what we're seeing in the data. Part of the reason, though, why sharing the information is so important about the actual risk is that there's a direct link between the perception of risk around drugs and whether or not kids will use them. Here's a couple of graphs, and I apologize, this is from an older version of the NISDA study. This is just the best graph I could find, but the trend has remained the same. What you're looking at here on the left is that past month binge drinking is twice as likely if kids don't feel it's a big deal. And past month marijuana use is 15 times more likely if they don't think it's a big deal. If a child thinks that something is harmful, they are less likely to do it. That's part of why when you think about like what drug do kids start with, it's never heroin, it's never meth. It's because the perceived risk of that is incredibly high. They start with substances that don't feel as risky to them. And then that's how the drug journey always begins, with something less risky. Because a kid who's never used drugs before, if a friend walks up and says, "Hey, like I've got some heroin, you want to tie off and inject?" No, they're never going to say yes to that, right? That's not going to happen. And so perceived risk is very important. This doesn't mean scare tactics, right? We want to be honest. And there's room for honest, scientifically grounded feedback to kids, particularly those who are on the bubble of like, do I want to do this? Do I not want to do this? Giving them honest, true information about what the risks are to the body, and then letting them decide what they want to do with it. So that's what we're looking at for brief advice. Now, if they're using on a regular basis, so monthly or weekly, so this isn't just like a mild experimenting, this is more of a regular thing, that's where you want to do the brief intervention. And the purpose of this, which should be short, 5 to 15 minutes, can fit ideally within an annual physical, is that you're trying to motivate enhance their motivation for change. And so MI, which we talked about before, is sitting within this stages of change model where we're trying to get someone closer to action. The first stage is pre-contemplation, which is where you're not even thinking about change. You don't see the benefit really, or you're very dismissive of it. Contemplation is when you're seriously thinking like maybe I should change. Maybe I shouldn't be smoking. Maybe I shouldn't be vaping. Then preparation is when you've decided, I am going to do this. I'm going to quit. And I'm getting ready to quit. So you're preparing for action, which is when you take the action to change. And then the last step is maintenance, where you're basically hardwiring the change into your new way of being. And so your goal, and just these, it's brief, right? 5 to 15 minutes, is to say, can I move them from one to the next? If possible, can I get the conversation started? Can I get someone who wasn't thinking about it to think about it? Or someone who's been thinking about it to decide, I'm going to do this, and I just don't know when yet. That sort of thing. And so what you want to do is ask questions that highlight the downsides of use and the benefits of change. So building that discrepancy, getting them to feel like, ooh, wait a second, like this is not really what I want for myself. So these are questions like, are there any downsides to getting high? Would anything get better if you stopped smoking? So thinking about a better future without it, the downsides to doing what they're doing, it builds that discrepancy. A really handy tool you can use if you're wondering, like, how do I have this brief interaction? How do I structure it? Is you can use what are called ruler interventions. And you can do this with a question about readiness, importance, or confidence. All three of those work really well for this. But the way it works is you ask the question, if you want to go with readiness, say we've got a young person who thinks that they're ready to stop using nicotine, but they're still ambivalent about it. They're in the middle. And so you might ask them, okay, so on a scale of 0 to 10, how ready are you to go for this, to give quitting a try? Where 0 is you're not ready at all, and 10 is you're ready to go. They're going to give you a number. And the neat part about this is no matter what number they give you, there is no wrong answer. So if, say, they give you a 5, smack dab in the middle, where they're not sure, well, you can ask as a follow-up, well, so why did you say 5 and not 2? And when you do that, they're going to tell you why they are more ready than not, even if ultimately they're in the middle. The other question that you can ask is you can refer up. So if they give you that 5 or even a lower number, but let's stick with 5. If they give you the 5, you can say, okay, well, so what do you think it would take to get your readiness from the 5 to something like an 8 or a 9 or a 10? Well, what are you missing? What would make you feel ready to go? And then the patient is going to tell you what would get them ready. And that is so much more valuable than you telling them what they need or what would work. This is their life, right? They know better than you, actually, what they need in terms of their own emotional process. And so if they tell it to you, that's very useful information. Now, if you are at a point where you're on the precipice of change, if you can obtain a commitment for action, that's ideal. Then if you can say something like, well, Do you feel like you're ready to start seeing that therapist this month, or try nicotine replacement, or whatever it is? That can be very helpful if you can, but don't push it, because it's always okay to schedule a follow-up. Again, this can be a slow process. You don't have to bite it all off in one moment, because you go too fast, you push, that's where you start to get pushed back. So some common mistakes around this ACT model: waiting too long to start talking about it in the first place. Again, don't hold it back so that you then have to fight against an existing inaccurate narrative. Second, asking judgmental, leading, or negatively framed questions like, "You don't smoke weed, do you?" Very easy then for them to just say, no, of course not, and move on, even if actually they are using THC products. You want to make sure you also use relevant terminology. So if someone is using THC, for example, sometimes I have heard personally, just anecdotally, that vaping THC, people will call that smoking, and vaping nicotine will be called vaping. So we just want to make sure that we're using the right terms so that we're not getting a no answer when we should be getting a yes because of how we're talking about it. So not doing ACT at all, another common mistake. Just either not asking a screening question, just breezing past it. Worth doing, particularly if someone's having a problem. Insisting on abstinence when smaller interim steps may be possible is also really helpful. Any step in the right direction is a good step. It's all helpful to the child. So we don't have to try to do too much. We don't have to go too fast. And in terms of not doing too much, it's also worth leaning, if you have integrated care with behavioral health, collaborative care, working with your partners over there can help a tremendous amount. So again, worth touching on briefly, there are going to be some kids who don't actually want to change yet. They're going to be pre-contemplative. And the metaphor that I like to use for as problems get worse is the boiling frog syndrome, where you're sitting in a pot of water that's on the stove and it's slowly heating up over time. But you don't feel it because it's going up 1 degree at a time for you. So it's this you don't see the difference little bit by little bit until all of a sudden you're finding yourself in this pot of hot water, this pot of boiling water, and you're wondering, how in the world did I get here? And the answer is 1 degree at a time. But sometimes folks don't see the trajectory and they don't see the progression, and they need a little bit more time. And so really working with a young person to determine, what do they want to do? Do they want to reduce substance use yet? Are they still pre-contemplative? Do they want to quit entirely, right? Is it harm reduction? Just making sure that we're attentive to where they're at and meeting the patient where they're at and helping them from there to get to where they want to go. And if that means in the short term, just kind of planting some seeds about cause and effect around substance use and seeing them back in 6 months or seeing them back in a year, then that in that moment might be what you can do. It's really just this question of assessing for, are there openings? Is there a problem? And then if there is, where are they at with it? How receptive are they? How close can we get them to this point of going over the edge towards change? Because if we can, it's worth doing. If it takes 2, 3, 4 visits, we want to schedule a more follow-up a little bit sooner, that can be okay too. So in terms then of the treatment side, treatment and support, the recommendation you give should account for any underlying reason for use, like anxiety, depression, etc., as well as the use itself. So the easy way to think about this is there can be biological, psychological, and social reasons why people use substances. It can be, again, just like an addictive biological process. It can be about coping. It can be about, in the case of, say, like stimulant misuse, like Ritalin and Adderall when they're not prescribed it. Maybe it's a lack of self-confidence. There's a reason psychologically, and then also socially. Is this a behavior that's being supported by the people around them and celebrated even, and where they're being rewarded for it? So really just trying to think, like, do we understand the why, biologically, psychologically, and socially? And if so, leveraging that. Now for nicotine specifically, we do have some resources that I want to mention. The first is that there's a text-based free program through the Truth Initiative called This Is Quitting, that you can just text that number to text ditch vape to that number, and you can go through the sign up process. There's actually evidence behind it, and it can be helpful. So if you have a child who's vaping, this can help. NRT, nicotine replacement therapy, is also a viable option. It is off-label, but the AAP, American Academy of Pediatrics, does recommend considering it for moderate to severe addiction with motivated youth to quit. So worth reading up on what they have to say about it, even though it is not FDA approved over 18. It's worth reading their recommendation and then using your clinical judgment. Lastly, therapy and behavioral health can be very helpful in terms of changing substance use patterns amongst youth, in large part because oftentimes those patterns are rooted in something emotional that maybe they're even having trouble verbalizing and identifying, and they need help doing that. So if we can help them do that, then we can get them to the point then where they resolve that underlying issue, the need for the substance can drop away, and that helps get the substance use to end as well. So just some very brief guidelines here on referrals, umbrella ideas here. As I mentioned before, any referrals should account for the underlying issue as well as the substance use itself. You want to match the modality to the individual. So if someone is, say, for example, really struggling with substances, using them almost every day, they're going to need a different level of care than a young person who is just experimenting or using it socially once per month, etc. So there are both outpatient and inpatient options for treatment. And again, if you are feeling like you need some guidance in terms of providing this recommendation, hooking the patient up with a behavioral health provider, ideally one with a specialty in addiction, is ideal. But just as a brief overview, what we're looking at on the outpatient side is an individual therapist, IOP or PHP, which stands for Intensive Outpatient Psychotherapy, or a program rather, and a partial hospitalization program. And an IOP is 3 hours a day, usually 5 days a week, sometimes a little less. PHP is 6 hours a day, 5 days a week. So they still go home at the end of the day. And there's a few more integrated aspects to the care there, but more time is really the primary thing there, in my opinion. Inpatient, there's detox if a young person needs it, and then there's also residential, where if they need to get out of their environment because it's, the peer group is toxic to them, or the home is not a safe place to be, if being out of the environment to build those new coping behaviors and habits and relationship with the substance is essential, there are facilities for that as well. You want to make sure, though, that when you're referring out, that wherever you're sending somebody to has third-party accreditation. So this would be Joint Commission, CARF, or Committee on Accreditation, or Council, on accreditation. Those are the three primary third-party accrediting agencies in behavioral health. A couple ideas for parents that you can pass along as well that can help. So this, of course, would be with consent ideally. So the confidentiality with the patient matters a lot. And if ideally you both decide that you should loop the parents in, or if you feel like you need to loop the parents in, there are some things that they can do to help. So first and foremost, you want them to support and reinforce new systems and coping mechanisms that the child needs to develop. And again, these are not necessarily things that you will be helping train them to do, right? Because you are not a behavioral health specialist. This is a primary care appointment. But the bottom line of it, and what you can tell parents, is that discipline alone, like punishment alone, is not going to cause the behavior to go extinct, right? We're not going to stop someone. If there's a child who's vaping, for example, on a regular basis, punishing them at best means they're going to just try to get sneakier, or when they graduate and go to college, then they're going to start it back up again. It's something where they're using it for a reason. So we've got to figure that out and address it. We also have to incentivize the healthy behaviors, not just disincentivize the unhealthy ones. And a lot of times parents just focus again on that discipline when they see the behaviors that are concerning to them. And that's important, right? That you do have to have consequences to actions. And we also need to give kids a better option, right? Like, how do we help them meet their needs in a way that is healthy and gets them the results that they want? And that's the next layer, right? You want the parents to help facilitate healthy coping for the child, whatever that means. A therapist, exercise, it's every situation is different, but encouraging them to help the child get into a program or work with a professional or whatever the solution might be, but to help them along that path. Provide that insight to parents that from a behavioral standpoint, we got to look beneath the waterline. We got to look at the why. It's not just about the behavior, even if that might be why you're looping them in, is because the behavior is very concerning or its trajectory looks negative. But we have to get beneath the waterline, and helping them see that too also can matter a lot. We can also help them discontinue unhealthy family dynamics. Some common ones that I've seen that you can certainly talk about is if sometimes there are parents who almost avoid their children because they're afraid of reactivity. Like if I challenge my son or daughter on this, they're going to throw a fit. I don't want to deal with it. I don't have time for it. I'm just not going to do it. That ultimately just teaches the child that if they throw a fit, they get what they want, which is not helpful to them. Actually, it's very counterproductive, and it doesn't solve the problem. So if that's a pattern that is happening, just helping them understand. Another way to put it is what you permit, you promote. If you permit it to occur, you're saying, let's do this again. Let's do it again and again and again. If a set of parents is buffering their child from natural consequences or the discomfort from their actions, like a very common one I see is that a child will be very disrespectful and mouth off at their parents, and there will be almost no consequence for that. There will be no negative downside to that. They will maybe get that catharsis of releasing stress. Maybe they'll even bully their parents into getting what they want, and it seems to work out for them. The natural consequence of that would be, well, they're not going to do you favors anymore, or you're going to lose privileges, or and that cause and effect is so important that kids feel the impact of their actions, as long as, for example, they're not tragic. Right? Like right now, there's a lot of fentanyl contaminating the drug supply. And so like an acceptable consequence would not be an overdose, right? Like there are certain things where we don't want people to experience them because they leave permanent damage, essentially. But this cause and effect between behavior and discomfort is really important for change. But another way, if a child touches a hot stove and they get burned, they're going to be like, ouch, that hurts. Maybe they'll do it one more time, but they'll learn really quick. Like that hurts. That is not a good idea. I'm gonna stop doing that. So if we stop someone from feeling that discomfort, they don't learn. I've also seen in some families there's this normalizing a lack of consequence from the maladaptive behaviors. So if a child learns like I just have to keep going, and eventually my parents will give up because they know that like they can't stop it anyway, and they're just gonna let me do what I want. Not doing the child any favors. And so if, again, you might not be privy to all this information, again, in family medicine, you might have a smaller slice of this pie, but if you have room for questions for the parent, or if you're aware of certain situations, that can be very important feedback for them to have in terms of how they can help their child along in the process of change or getting to the point where they're ready for change. So let's sum everything up for today. Starting again back at the beginning, teens are facing a tremendous amount of stress right now from a number of different angles, and that leads them to look for a solution. Substance use is 95% of the time, in my opinion, trying to meet some emotional need, social need, like wanting to be part, or some internal tension that we're trying to relieve, including boredom. Right? It can be that more focused on that euphoria, but there's a reason for it. And substance use feels like a solution. All behaviors have a purpose. You have to know the why as well as the what. So from our perspective as healthcare providers, we can normalize the conversation with our patients early. We can communicate with love, active listening, offering feedback in a way that sandwiches it inside of autonomy, validating the emotions even if the behaviors are less than healthy, and showing empathy. We can screen and ask questions regularly when we see our patients, when they come in. We can reinforce healthy choices. So if someone's making healthy choices, don't just be like, okay, that's baseline, but actually give them some credit for that. Create that positive experience. We can provide education in low acuity cases. So if someone doesn't know what the health impacts are, we can tell them what they are. And that we can help them make a decision that's healthier next time because they're aware of the implications. And we can loop parents in and connect to care when indicated, because at a certain point, if we are feeling it's getting worse, more intense, there's a strong chance it will continue in that direction unless something happens. And that is where the family system, which we talked about a second ago, as well as just the parental influence and their ability to access care, is so important. So Thank you again for your time and attention at this training. Really appreciate your interest in the topic. If you have questions, please feel free to reach out. Again, my email is aaron@weinerphd.com. So thank you once more, and I hope to see you at another one of these trainings.